4.
Out of expected.
Expected as 17.
So far you are not there.
We'll keep joining.
Keep joining if they will join.
We can start. We can start.
Ladies and gentlemen, let's proceed to our last section of today's lecture. We'll look at primary congenital glaucoma. Congenital, normally you are born with a glaucoma. Or if you are not born with a glaucoma, within the first few months of your life, you will start exhibiting signs of glaucoma. In terms of genetics, most cases of primary congenital glaucoma are sporadic. There is no established genetic flow. You can say, no, it's autosomal dominant, it's inherited like that. It's sporadic, means it can occur in any variation. So most of the cases of primary congenital are sporadic, inheritance, autosomal, recessive in about 10% of cases, with incomplete penetrance. It's linked to, when we say linked to 3 points or 3 loci, these are the 3. These are, when they go on to the genes, these are the points where they find that the genetics is not correct. That leads to congenital glaucoma. So when they say linked to this, it is these points which they suspect to be wrong, which ultimately leads to congenital glaucoma. Pathogenesis, you have impaired aqueous outflow in primary congenital glaucoma, and is caused by maldevelopment of the anterior chamber angle. Remember, the aqueous is produced from the ciliary processes. The ciliary processes are in the posterior chamber. Fluid is produced from those ciliary processes. The fluid comes through the pupil to enter the anterior chamber. Then the aqueous is drained in the angle of the anterior chamber. So in congenital glaucoma, there is maldevelopment and poor development of the anterior chamber, the angle. So fluid may come, but it's not being drained appropriately away. Clinically, there is absence of the ciliary body band due to amorphous material that obscures the trabeculum. Classification of primary congenital glaucoma. You have one true congenital glaucoma. 40% of all cases are true. Intraocular pressure is elevated during the intrauterine life. In fact, before the child is born, already the pressure is elevated. Then you've got infantile glaucoma. 55% of all cases, it manifests itself prior to the 3rd birthday. It's an infant already born. To be called an infant, first you have to be born. So infantile glaucoma means someone is born, then they develop that glaucoma. 55%, and this is usually most of them before the 3rd birthday. You find the eyes are enlarging. Juvenile glaucoma is the least common. They've passed through these stages They are now more or less juvenile. Who are the juveniles? 12 or 18, somewhere there. That's when they have the glaucoma. Pressure rise occurs after third birthday, but below the age of 16. Gonioscopy may be normal, classified as having juvenile open angle glaucoma. Diagnosis. Most common of the congenital glaucoma affects 1 in 10,000 births, and 65% of patients are boys. 65 is not a lot of difference, but there is that bias, more boys affected than girls. When they say 65, it doesn't mean it cannot occur in girls. You understand? When they say 65% is this, doesn't mean it can occur in a female child. Clinical features depend on the age of onset of the intraocular pressure rise. Both eyes are affected in 75% of cases, and infrequently may be asymmetrical, one eye more affected than the other. What you have is corneal hazy, often first sign noticed by the patients. Because of the rise of pressure, fluid starts entering into the cornea, and the cornea becomes hazy. Everyone knows the cornea is supposed to be clear, black at least. Immediately it starts appearing whitish because of fluid that has gone into the cornea. Even the mother or the child will be saying, so corneal hazy is often the first sign noticed by the parents. It's often a sign they will bring to the hospital, because especially when it's asymmetrical, more in one eye. Quickly they will bring the child. White. This corneal hazy is caused by epithelial stroma edema due to the raised intraocular pressure. The epithelium at the back of the cornea is broken, and fluid is entering now the cornea thickness. And the whole cornea, instead of being clear, it becomes cloud and opaque. May be associated with lacrimation and blepharospasm. Bull thymus. Bull thymus is called bull thymus because you have an eye as big as a cow's. The eye gets enlarged. That's a bull thymus. You know, large eye due to stretching of eye due to raised intraocular pressure. The eye affected will be big. The other one, if it's not affected, it looks smaller, but that's the normal one. The child can see with that eye, can't see with a big eye. As sclera stretches, it becomes thinner and translucent. The eye takes on a blue appearance due to the enhanced visualization of the underlying uvea. Breaks in Descemet's membrane do occur secondary to corneal stretching and may be associated with sudden influx of fluid into the corneal stroma. This cornea is stretching because of fluid now getting in there. It's not being drained away. So the cornea gets stretched, and the eye becomes a big one. That's what they are referring to as bull thymus. When you do a cross section, there are breaks in the Descemet's membrane because of the stretching. Hub striae represent healed breaks in Descemet's membrane. These hub striae, the healed breaks, will appear white lines, like whitish lines. It means the cornea initially stretched up, had breaks there, then those breaks, as they heal, they appear white. It's a later stage you see. Okay. Infants may is this? This I don't need. Optic disc capping. The pressure obviously impacts on the disc, and like glaucoma, when there is pressure rise, there is capping of the disc. So even in this one, when there is bulging of the whole eye because of excess fluid, the cap is also capped. This may regress, the capping of the disc is because of the excessive fluid. When an operation is done and the flow is gone nicely, this may regress. But for others, to regress, first you have to go to the hospital where they can treat you, you know. Management. Obviously, any management requires first initial assessment of what you are going to manage. You have to be very sure. Initial evaluation performed under GA with IV ketamine. This is a newborn baby. Yeah. You check the intraocular pressure, measure using Perkins tonometer or a tono pen. Get a corneal diameter, measure vertical and horizontal diameters. It will show you that it is enlarged from the normal. You know the normal. 11 millimeters before 1 year, view with suspicion. 13 millimeters after 1 year, view with suspicion. When we say view with suspicion, it means it's in the abnormal range. So a child should not have a 13 millimeters diameter of the cornea at 1 year. There it means it's enlarging, it's too big. 14 millimeters is typical of advanced bulthamos. So you can have a diameter of 11 to 14 millimeters. You do this with done with in the direct gonio lens. You can measure. First, you also do a gonioscopy. Gonioscopy, what does it do? Help you to do? To check the angle. Okay? The angle, to visualize the angle, you use a gonioscopy. Okay. So you are going to measure the diameter, but let me warn you, this gonioscopy can only be successfully be done if the cornea is a bit clear. If it's completely opaque, you will not see through that opaque cornea to the angle, even if you use a gonio lens. But in early stages, you might be able to see. You're trying to see the angle where there is maldevelopment or not. Kwamana. Trabeculectomy with a shunt. What is this I'm saying? Questions, ladies and gentlemen.
What is GA on evaluation?
GA, general anesthesia. Anesthesia can be local eye drops, can be local injection, or GA. GA, when they say under GA, it's general anesthesia. The patient is completely sleeps. When you are operating, you are going to cut one or two things. You don't cut. Usually, you go under GA. If you are going to open someone's tummy, you have to use general anesthesia so that they are completely gone. and you are monitoring their breathing and everything. Then you can open the tummy, cut out this, eventually suture, and then take them to their bed. That's GA. A child like this, if you are going to do an operation, it has to be under GA because the child will not cooperate with you touching the eyes. First, they will be crying uncontrollably. So unless you put them under GA, they'll be completely quiet and, you know. So all these are done under GA. It's a child, they cannot tolerate you or touching. Even you, sometimes you do these operations, first you want to establish exactly what is there and whether you can do the next stage to repair. So GA is an abbreviation, general anesthesia. There is what is called general anesthesia, whether you give someone a drug to sleep, you can open the tummy, they are not feeling any pain, you can cut anything there, whatever you are supposed to cut, and finally suture. They're under GA, no problem. After that, they will come out. Or you can do any surgery under local anesthesia, LOA. You'll find the little, when they are writing in these files, under local, LOA. When they say under GA means general anesthesia, complete sleep, the patient completely sleeps and is being monitored, the breathing and everything is being managed by the anesthetist, while the surgeon there is busy opening up and operating. Questions, ladies and gentlemen. You've seen performed initial evaluation performed under GA with IV ketamine. Slide number 7. They're checking it out. Because the child will not allow you to be touching there. Now, even me, I can't allow you. But we do that even in the wards because we're putting, for an adult, you can put local anesthetic drops, it's numb, then you can take the pressure. For a child, anything touching the eye, the child is not that cooperative. Will refuse, will cry. So you do a GA like that.
There's a question.
Yes, the question.
By theory. She's asking that when do we do this examination?
When is it done? It's better done first 2-3 weeks of childbirth. But can be done at a later stage because the child will be born. It's a question of the time the child is brought to the hospital. It's one thing to be born. If you are in a rural area, by the time you reach the hospital, it will take you even a month. You can still do the procedure. Want to examine what is there. If the child is born in the hospital, they can wait maybe another 1 week, then you do the test, the examination, and you proceed. Because after examining, then you proceed with a solution, what you think is the best solution for a child. Any other question? When do we do this examination? Okay. When you are evaluating for glaucoma? No, it's not when we're evaluating for glaucoma. When a child is born, they're not looking for glaucoma. They do examine children after they are born. Before you discharge the child, it will give it to the mother. Isn't it? So once that examination is what will show you that the child's eye is bigger than what is supposed to be normal. It means an eye person must have a look. An eye person must have. But it's better done quickly before the eye is completely lost with the high pressure. You know, it's not like Mukes the next year, no.
I think this the pressure is high
Yes,
inside, meaning there will be
damage to the eye.
some sort of pain.
Yeah.
Meaning,
But the child won't tell you have a pain.
but there will be, I think, because they'll be crying like so.
When a child is being discharged, those are the things people must examine. Whether the child is okay. Even the mother will know a normal baby and they are not, especially if she's not the lady, so it's not the first child. But even if it's the first child, the grandmother will be there. Let's see what Mwishkuru has come with. Remember congenital? The eye swells up before, you know. When evaluating for glaucoma, not on evaluation. No, all children before they are discharged, you have to there's a evaluation of the child. They examine them completely, not only for glaucoma. You have to check that they've got the fingers intact and everything is okay before you give for a discharge from the hospital. Unless they're born in the village, you know, then the mother will look and no, it's not supposed to. Then they rush to the hospital. Those are the options you get in Zambia. Child born at home, whereas where the Kaswiri is there, then no, they come to the hospital. Who is it? Yes.
Alinani,
Ali?
Alinani Simanza.
Alinani Siwanza.
Mm-hmm.
Questions, not my thank you. Let me answer all the questions, and that's when we can go. Thank you. So tomorrow we'll plan for tomorrow. Let's see, once this is gone, we'll look at what is there for tomorrow. What we can tackle tomorrow.
Tomorrow is weekend.
Oh, people, thank you. Monday, okay, Monday.